all, I'm Dr. Sujata Basavaraj, President of American Society of Cosmetic Dentistry. And in today's podcast, we will be talking about coronavirus, COVID-19. And mainly what we will be covering today is how to take care of your practice, your employees, and your patients. For that, I have Dr. Puttaiah here, who is a public health dentist, epidemiologist, a professor, and who has published more than 90 articles.
Thank you, Dr. Basavaraj. I'm Puttaiah. I'm a public health dentist and a trained epidemiologist, also a shoe-leather epidemiologist, and I worked in oral cancer and oral precancers before I came to the United States. I joined a master's program in the United States in epidemiology and international health. And after I completed that, I did a residency in dental public health at UAB, soon after which I joined a Johnson & Johnson postdoctoral fellowship in infectious diseases at the UT Health Science Center in San Antonio Dental School under the tutelage of Dr. James Cotton. So I spent about 4 years out there learning the ins and outs of infectious diseases, infection control as applicable to dentistry. Soon after which, in 1997, I started off as a tenure-track faculty at Texas A&M College of Dentistry in Dallas. It used to be called Baylor College of Dentistry before. I was basically a part of the diagnostic sciences faculty. We taught treatment planning and oral diagnosis. Apart from that, I also taught infection control, OSHA, and HIPAA. I've provided over 300 continuing dental education programs worldwide. I've published over 90 articles, including peer review papers, a bunch of them. I'm an ad hoc reviewer for the Journal of American Dental Association, the Journal of Dental Education, and I'm an editor at large for the Journal of Contemporary Dental Practice. On multiple occasions, I've reviewed HRSA grants and PCORI grants. I've been a recipient of multiple NIH or NIDCR grants and about 24 industry grants. I also serve as the scientific director for the dental safety programs of the International College of Dentists, and I retired from state service as a fully tenured professor in September of 2019, and I'm also the owner and the president of OSHA for Dental LLC. It's an educational company where we provide educational programs on infection control, OSHA, and HIPAA.
Welcome to the podcast, Dr. Puttaiah. To begin with, for benefit of our viewers, could you please tell us what is COVID-19?
Before we get into the nitty-gritty of today's COVID podcast, let's talk a little bit about the history of epidemics and pandemics. There were epidemics and pandemics of infectious diseases around the world. In 429 BC, there was the plague of Athens. In 165, there was the Antonine plague. In 541, there was a plague of Justinian. In 1347, the Black Death. 1509, smallpox and measles in the New World. 1618, typhus during the 30-Year War. 1775, smallpox. 1852, cholera. 1918, influenza. 2003, SARS. 2012, MERS. 2014, Zika. 2015, Ebola. 2015, measles. And 2019, COVID-19, or the coronavirus infection that is going on.
So, Dr. Puttaiah, what are the common types of coronaviruses affecting humans?
Here is a mind map of our coronavirus. Coronavirus, actually, this COVID-19 today, as we are facing, belongs to a family of coronaviruses, and there are approximately 7 coronaviruses, that is the 229E alpha coronavirus, NL63 coronavirus, OC43 coronavirus, HKU1 beta coronavirus, MERS-CoV, SARS-CoV. The last one, that is what we're facing, is coronavirus, which belongs to the SARS family. SARS-CoV-2.
So, Dr. Puttaiah, what are the sources of coronavirus? What is the origin of it?
Among the 7 different types of coronaviruses we have come across now, they're both found in animals and humans. There is a transfer between animals and animals to humans. These are basically zoonotic diseases. The more we go into the lands of the animals or we encroach on their common habitat, we are bound to be exposed to them, and it has happened multiple times over hundreds of years. The basic routes of transmission among humans is through droplets, contact, or fomites. But there's a new kid on the block. For the past couple of weeks, everybody's been talking about airborne transmission. So let me explain a little bit about what a droplet is and what is an airborne particle. Airborne particles are normally less than 5 microns in diameter. They are light and they can stay suspended in the air for hours. There are many people who say, oh, it can stay for 3 hours. Some people say that it will stay for 24 hours. Some people claim it can stay for 48 hours in the ambient air. Whereas droplets, when a person coughs, and if it's a larger droplet, a larger particle, which is about greater than 5 microns or more, they're heavier and they're gravity dependent, and they tend to settle down on surfaces. Or if a person is breathing and the mouth is open, they can get onto the mucus or even into the alveoli. So that is direct transmission, basically. So airborne particles are suspended in the air, and when we breathe the air, we actually inhale the particles. The droplets are normally kind of implanted onto our physical surface of either the mucosa or the alveolus. All these days they were talking about you got to keep 3 to 6 feet away from another person, kind of sequester yourself so that when the person coughs, don't pick up that particle, it doesn't land on you. But in reality, if it is airborne, when a person coughs, you can have coughs or sneezes, you can have multiple size particles. Some could be lesser than 5 microns, some could be more than 5 microns. So it all depends. So now, if you are in a room with about 4 or 5 people sitting about 6 feet away, let's say, between each other, but if a person who is infected breathes or sneezes, there could be a segment of these particles that could be suspended in the air, and others who are more than 6 feet away can also breathe into them.
What are the various controls we can put in dental practices?
With respect to control methods in dentistry, I'm talking of specific to dentistry, not your social living and other stuff. The first step is communication. The second step is work practice controls. The third, basically, are engineering controls. The fourth is immunization and leading a healthy lifestyle. And the fifth is reducing contact with patients that could be at a higher risk of infecting you or your staff.
How do we best communicate with our patients?
So, communicating with the patients, it's very important. The first thing is to be proactive in contacting and sending messages, through phone calls, text, or emails at least a day prior to their scheduled appointment, and letting them know not to come if you're not feeling well. The next one is to post a notice locally on your door, on your office door, so that patients, if they're walking in and they're not feeling good, they can go back and call you and reschedule an appointment. You can also post it proactively on your website during these epidemics. You can post it inside your office just before they sign in, just in case they miss your emails, your text messages, your posting on the door. When they're signing in, there should be at least a small plaque which says, if you're not feeling well, please do not sign up or sign in. leave, call us back. Another aspect is thinking about yourself and your employees. If you are not feeling well or are feeling a little tired and feverish, don't go to the clinic. You might be actually sick. If your employees have similar issues, ask them not to come. Have a good policy within your clinic, letting people know that if you're not feeling well, please don't come in and infect others, including patients in the clinic. You can reduce elective care. Most of dental care is elective care. For example, hygiene maintenance is elective care. Preventive care, like, sealants and fluorides and putting SDF, that is all elective. Then low-level disease control can also be elective. What you could do, or you should do also, consider this. You can keep your clinic open with a skeletal staff to handle emergencies. Major toothaches, if there's somebody's got an abscess that needs an IND, or if somebody's had a true emergency, as you can call it, you could actually get the patient in for a brief visit, be very specific and to the point, concentrate on the same focused issue, treat the patient, send them home. If they have major emergency issues, you can always refer them to a tertiary medical center or a dental school where there are oral surgeons and other high-end care providers, and there is a better possibility of them having N95 respirators and so on. The next method of control, basically work practice controls. You should follow strict personal hygiene and cough etiquette. More hand washing. Hand wipes with alcohol or an antiseptic is a good idea. I don't like pure alcohol. I'd like to use the alcohol after a hand wash. If you cannot wash your hands, you have to use at least a wipe with alcohol and or other antimicrobials, and they are good. Then face masks control droplet. You have to understand the common face masks we use in dentistry. They basically are to control splash or spatter, droplet particles from hitting your face or your mucosa. These masks in no way can actually control the flow of airborne particles because there's always going to be a blow-by, and a blow-by is when the air does not go through the mask material but actually slips through the side and the top of the masks. Trying to use an N95 is very difficult. I've used an N95 mask or a respirator multiple times during my fellowship, while treating TB patients, while treating highly infectious patients. Yes, you can't breathe through them for more than 15 minutes. Your face turns red. Then, if you want to also control, you can use a face shield and a mask underneath. That's another option. Use disposable PPE. Try and get rid of the PPE as soon as possible. Strict aseptic techniques. Do not go and put your dirty hands onto something else to pick up supplies or touch common surfaces or non-barriered surfaces. Diligent surface disinfection. Disinfection of common surfaces. Use hand instruments if you have to do prophy. Reduce patient visit time. Use a pre-procedural mouth rinse, an antimicrobial mouth rinse. When you go home, launder your scrubs immediately and go have a shower. Provide a face mask to people in the waiting areas, in case they're coughing or they're sniffling. Give them a face mask so that they don't spew out particulate matter around your atmosphere.
And what about the engineering controls that we can put?
The next step is engineering controls. You have to use increased use of a rubber dam and high volume evacuation system. Then you also have options of HVE attached to scalers, and then there are also other devices that are attached to scalers and also the HVE device which are placed intraorally. the main thing here is you have to try and get rid of the bioaerosols that stay suspended in the ambient air by increasing the air exchanges. That's number one. By using air scrubbing devices. These are basically devices that are either freestanding in the room or they could be retrofitted or attached to the HVAC system. They do have multiple layers of HEPA and carbon filters. They also have a UV chamber. So once the air is sucked in, the particulate matter are actually trapped. A lot of them are trapped onto the filter aspect of the HEPA filter. And what else goes into the UV chamber is denatured by the high intensity UV light, and this air is circulated back into your room, and this actually increases the air efficiency and even air quality without you doing much. Okay, then the next step is immunization and other procedures. You need to go for your flu shots. I mean, that's a gimme. You're a healthcare provider. Until and unless you have something that prevents you, physically prevents you from going for a flu shot, you should take your flu shots. You should encourage your staff to take their flu shots. Once a vaccine becomes available for COVID, you may want to take that shot also. It may be incorporated into the annual influenza flu shot. You need to eat well, drink plenty of fluids, exercise well, and rest. I have two examples of the air scrubbers. One is called Surgically Clean Air. I think it's a Canadian company, and now they are available in the US, and they have multiple sizes of the devices. They have a HEPA filter, high intensity UV light. They claim increased circulation of air through the system. It decontaminates the air. It denatures particulate matter and bioaerosols. This is another device. It's made by a company called RGF Biocontrols, and they have both independent standing units for individual rooms as well as inline or through your HVAC systems. This also has very similar claims, components as the previous one. And
Can you list some sources that our viewers can go to if they need more information on this one?
Doc, I'm not currently aware of any particular podcast or a course that is being offered right now on COVID. But if people want to learn infection control, occupational safety, Health Information Portability and Accountability Act, the Texas House Bill 300 and its amendments, and about emerging diseases, they are more than welcome to visit www.oshafordental.com, and that is my educational website. And thank you for giving me this opportunity. As of last week, OSHA has come up with a document on guidance for COVID-19 for workplaces. So you may want to look into that. You can go to www.osha.gov and search for COVID, and there should be a guidance. This is not a final rule or anything, but it's a guidance, and it's a good one to read. Actually, it's not too long. It's about 30 pages, and I've read it, and it's a good start.